Hi, my name is Ryan Arachi. I'm currently in the ethics class with you guys. Um, you have to forgive me. I'm not comfortable speaking in front of a camera. I'm used to having people in front of me and being able to react to them. I've been a nurse for about 9 years now. Started my nursing career at the women's prison and then went to mental health. Worked at Meadowood for 7 years. And then now I'm a dialysis nurse. Um, so with that in mind, um, I did my paper on dialysis and the withdrawing and withholding of care, um, because I've had a couple experiences with patients who personally I would not have recommended continuing care. One patient, she was 47, came in. Husband had a durable power of attorney, and she wants everything, and she had moments of clarity, and but a lot of times, she was not with it, and deemed that she couldn't make her own decision. So the durable power of attorney came in. So she was diabetic, had a gangrene in her foot. Um, Ended up going septic, needed dialysis. But the problem was her blood pressure didn't really want to tolerate the dialysis. So then she's on pressors, and that led to necrosis in her hands. So she lost both of her legs. They didn't take her hands um, prior to discharge, but the whole time, like, she had a poor prognosis, poor quality of life. She's now bedbound. She's out of it. Um, and the husband just, no, she wants everything done, keep her alive, keep her, she's still there. Um, and again, we're held to the decisions he was making because of the durable power of attorney, and she couldn't make her own decisions, um, which didn't rub me the right way. So I do dialysis currently. What it does is it can remove a buildup of fluid, and it can balance your electrolytes. Is basically what it does. It's a renal replacement. So if your kidneys stop working, they take the place of what your kidneys do. Problem is it doesn't cure anything. It can buy you time, but it doesn't address the underlying causes of why your electrolytes are imbalanced or why you're building up fluid. So there's two types of kidney injury. Um, there's acute kidney injury, and then there's chronic kidney disease. One's progressive. Um, for those of you that aren't nurses, the chronic is progressive, and the acute can happen if you're dehydrated, if you get in an accident, if you have contrast dye. It can make your kidneys stop working for a little bit. We do dialysis, and then hopefully they return. Um, so there's two different reasons why you're on dialysis. So there's a there's a thought process behind offering everyone dialysis. And some of the ethical issues that I cover are, starting people. Like, is it ethical to start people on dialysis? And is it ethical to withdraw dialysis knowing that they need this to survive because they will die without it? So the ethical issues I cover in my paper are beneficence, veracity, autonomy, justice, and non-maleficence. Um, if we use the nurse's code of ethics, the second provision of that states that the nurse's primary commitments to the patient. And the first provision is that the nurse practices with compassion and respect for the inherent dignity, worth, and unique attributes of every person. Um, so that's treating everyone like an individual and putting, their needs and um, concerns first. So we have to advocate for the patient, as I did with the patient I told you earlier, but I was unsuccessful. Um, but when it comes to withdrawing and initiating dialysis, there's some ethical things to consider. So beneficence, we do have the duty to the patient above all, other considerations. And we have to honor their autonomy. Sometimes people think, make decisions that, you don't agree with, but if they're informed and they know what's going on, then that's their right. Um, but we also have to take into account the burden of treatment. Dialysis itself has a large burden of treatment. Um, it's 4 hours a day, 3 days a week. Um, there's cost. I mean, it's like $90,000 a year on Medicare. Private insurance is going to be more. So that is there. Also, I've seen issues with veracity, where the healthcare providers don't want to tell them the bad parts of it. It's like, oh yeah, we can take that fluid off and we can remove that potassium so your heart dysrhythmia goes away, but they don't tell them that you're going to have a fluid restriction of 1,200 milliliters a day, which is roughly 5 cups of liquid a day, um, and that you're going to have to go to this treatment every other day for the rest of your life for 4 hours a pop. Um, so if they tell them everything and then we trust in the patient's autonomy, um, sometimes their quality of life, sometimes what they view as a good quality of life doesn't line up with what we would want. Um, I've had a guy that doesn't want to do dialysis because he can't stand the fluid restriction. Okay, it impedes his quality of life, and he'd rather live a short life where he drinks his beer and goes about his day. Um, the practitioners need to take into account justice. There's only so many beds, there's only so many treatments, there's only so much money and resources that are available. Are you going to start a 97-year-old woman with dementia on dialysis, or are you going to save it for someone who can benefit more from it, like an acute kidney injury which may regain function? And then non-maleficence, sometimes the burden of treatment hurts the patient more, in their opinion. I saw a statistic that 80% of the extra days lived due to dialysis are spent either in dialysis or in the hospital due to complications of dialysis. All of these things need to be, addressed and taken into account when we're starting new patients on dialysis. Okay. And I'm over time already. So thank you for your time, and I look forward to your questions and comments.